Good afternoon and good evening, everybody, to everybody attending this next webinar session of our Indonesia Social Science webinar series. This is the lecture series that's organized jointly by the Southeast Asia Center of the University of Sydney, the Southeast Asia program of Cornell University, and my own institute, the Royal Netherlands Institute for Caribbean and Southeast Asian Studies, or in brief, KITLV. I thank these institutes for making this webinar series possible, all the people that you don't see behind the screen making this possible. My name is Wart Berenschot. I'm a researcher at KITLV and a professor in comparative political anthropology at the University of Amsterdam, and I will be chairing this session. Today, we'll have a special event where we'll be looking back at the lessons that can be drawn from Indonesia's experience with the COVID-19 pandemic. The coronavirus has wreaked havoc across the world, but also in Indonesia. And as the pandemic is subsiding, we felt that this is a good moment to look back and reflect on how Indonesia's health system has coped with this unprecedented challenge. And I think there are no better speakers to do this than our two speakers for today. Our main speaker is Professor Laksono Trisnantoro. He is a professor in health policy and administration at the Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada in Indonesia. And he obtained his MD from Universitas Gadjah Mada in 1987 already, and then a Master of Science from the University of York in the UK, and then his PhD in 1993 from the London School of Hygiene and Tropical Medicine. And then he has developed a distinguished and very long career working on health policy and administration, particularly health service industry, and is not only an academic, but also worked in policy advice, consultancy, and is currently also serving as a staff khusus at the Ministry of Health. He will be then later joined as discussant by Retna Hanani. And Retna Hanani is a PhD candidate at my university, the University of Amsterdam, where she's writing a dissertation on healthcare reform and access to healthcare in Indonesia, which I can all recommend you to read once it's done. And she's also a lecturer at the Faculty of Social and Political Science at the University of Diponegoro in Semarang. And I point to two publications that she's written on maintaining civic space and women activists during the corona pandemic, and a very recent publication in BMG Global Health on Indonesia's national health insurance responsiveness. So look that up. But now, with no more further ado, as we have a lot to talk about in 1 hour, we'll go straight to Professor Laksono with one more housekeeping remark from me. We'll have Professor Laksono's talk, a little comments from Retna Hanani, and then we'll have about 20 minutes for question and answer, and you will be able to post your questions in the Q&A chat. To save time, there will be no opportunity to speak for you, but you are very much encouraged and invited to type your questions in the Q&A, and the speakers will do their best to address them. So with that, to Professor Laksono.
Okay, thank you, Wart. Yes, can you hear me?
Yes, I can hear you fine.
Okay, good morning, afternoon, and also good evening, everybody. So thank you very much, Wart, to invite me for speaking in this very, very prestigious event. Okay, so I will share my screen as possible. Yes. Okay, so the title is very interesting. We have the painful lesson from COVID-19's pandemic, but also we have some optimism that in the future we will have a better situation. So this is the point of my presentations. Okay, let's see the the content, we have three parts. One is the health system before COVID-19 pandemic, and we can see what we call the systemic weaknesses. And then the impact of COVID-19 pandemic. It's a bitter lessons. It's painful, yes. And then the response, how to transform the health system. So these three parts of my presentations, and I try to finish in 25 to 30 minutes. Okay, but okay, let's see what the situation before COVID-19 pandemic. This is an important issue because if you look at when the pandemic COVID-19 started, it was in the beginning of our new or the second term of our presidency, Pak Jokowi. Okay, so we can see if you look at the health system function before the pandemic, there are some indicators of how the achievement of the health system, and frankly speaking, it's not optimal or it's not so good. So the health system function didn't work well. And we can see the components of the health system function can be the financing, regulations, human resources, development, and then health services, medical device, and pharmaceutical industry, comprehensive education, and some other things. So we can see that if you look at the target of the system before the pandemic is actually many below the target, from the maternal mortality rates per 100,000 live births, the worsening prevalence, malaria eliminations, and also if we go to the ratio of GP per 1,000 population is still lag behind the target. Okay. Also, the hospital bed ratio, and if you look at Indonesian's structure or size is so big, and we are archipelago, so we can see that even for the hospital bed ratio per 1,000 population is still not so good, and this is also the placement or the distribution of the hospital still clustering in Java. I will go to this issue later on. Okay, so many of the indicators is not optimal. And then if we compare to other countries in ASEAN, we have still lag behind. So most of our indicators is not so good. Okay. And then this is very important issue that we have to look for the economic situation, and this is very related to the financing of health system. So actually, if we look at our GDP, this is the blue graph, is the increase of GDP from around 4,000 trillion rupiah, becoming around 16,000 trillion rupiah, and it is spent about 12 years. It is an increase very, very sharply, but we have problems of the tax collection. The tax collection, the red dots, still very, very slow in relatively compared to the GDP improvement. And then it's less than 10%, it's around 9.5%, always like this. And then the non-tax revenue also very, very limited. So our government actually a very what was like a shortage of income. Yeah. But we have to fund many things, including health sector. That is the point. And then if you look at our health budget before the COVID, it is very interesting that the increased spending is sharply for health social security. And this is more curative than preventive. And then the other DGs is like it was flattening like this, flattening during the last 5 years before the pandemic. And then health system suffers from the problems of inequity. So if you look at the map of Indonesia, this is the number of the pulmonologists, the lung specialists, the medical doctors, yes, it is very clear that most of the doctors cluster in Java, and if you go to the eastern part of Indonesia, in Sulawesi, Maluku, and Papua, and also NTT, we have still a very acute shortage of pulmonologists. So this is the fact of the geographical inequity. And also we have problems of the inequity of the members of the social insurance security, yeah, the BPJS. So you can see that we have the deficit members groups, and then we have the surplus, yes. And it is interesting that the informal workers, they are relatively more affluent. It has huge deficit like this. The red color is the symbol of the deficit, and the green one is the surplus of the member. So you can see that many or the much of the budget that should be used by the poor is used by the middle up society. That is the problem of the membership inequity. And then we have also the problem of the imported vaccine, drugs, and medical devices. And actually, if you look at this graph, before the COVID-19, we have very small number of local content industry in medical devices, and also in pharmaceutical. And the COVID-19 increased very sharply the number of the industry for having medical devices. And then that is the problem of the surveillance system. Actually, we don't have a good national surveillance network. Actually, this surveillance network should be based on the local government surveillance system. Okay, and this is the point. We don't have enough resources, human resources, and also financial resources for surveillance. And then if you look at the way of doing the management system of the head social security agency, the BPJS, is centralized, while the local government head system is a decentralized approach concerning the local government. So we have like two unmatched head system, and then this is the financing system. So that is the point that in 2019, there was a big need for reforming health system, in which health system reform is defined as sustained, purposeful change to improve the efficiency, equity, and effectiveness of the health sectors. So Bappenas, the Central Bureau of Planning, realized that this kind of situation should be reformed for having a better efficiency, better equity, and more effectiveness of the health sector. This is the point before the pandemic COVID-19. But the COVID-19 pandemic struck in 2020 in March and April. So now we have how the impact of this such catastrophic pandemic happening to our health system. Let's see. So the lessons, the bitter lesson, we have the direct impact. The number of cases started in April, May here, and then increase. We have the first peak here, and then slow down, and then the second peak, and this is related to the Delta variants of the COVID-19. This is the worst, yes. And then we just come from the third wave. This is the Omicron variants, yeah. Okay, and if you look at the direct impact of the mortality of the COVID-19, this Delta peak is the worst. So we can see our health system suffer from this kind of catastrophic impact of COVID-19. And then if you look at more detail, we have problems of the availability of hospital bed, especially in this the second wave, and then also the oxygen crisis is very bad at the time. And then we have many social sector policies like large-scale social restrictions and invitations. It is very, very dynamic, and the terms that we can use is like we build a ship while we are sailing. Yes. So there are so many things that we don't understand, that we didn't understand much about the social sector policies, but trying to have like a good and proper policy. This is under the flashback of a not so good health system. And then family allowances, and then how the community hospices for treating COVID-19 patients. And then we have also indirect impact, like the UNICEF has many studies about how the primary health services were significantly disrupted or suspended in the early part of the pandemic. In particular, the closure of Posyandu. Posyandu is the post of health system for 3 to 6 months. And many families have uncertainty and worries about COVID-19 testing, quarantine, vaccination, and the stigma of testing positive. And many concerns were shared by misinformation on social media. So this is very, very interesting issue that social media is becoming like battle of hoax and information. And people are confused with the content of social media, like the lockdown debate, and then how to get the right vaccine, and also the halal and haram issue of the vaccine. Also, so many things we suffer from this social media, like fanfare or something like that. Yeah. And then this one lets families in many locations to rely more on village level health providers and facilities, rather than visiting the proper puskesmas, health centers, and hospitals, unless they were seriously ill. Okay. And then urban families were more immediately affected by the pandemic than rural families. Okay. And they have also lost income, education of children, and lack of clear and trusted information about COVID-19 across the country. And many families' income were negatively affected. Okay. And also migrant workers and informal laborers continue to face challenges almost a year later. So, and then other things like for children health with the data indicator like this. So because the social distance policy, so many of the below 5 health programs for the kids, health program for the kids below 5 years, it is affected like this. So like the food supplement, and then food exclusive breastfeeding for the baby, many of this program is effective. And the study of the severity we can see in the this map is almost from the 200 district. There are so many things that happening, and they have like severe impact on this district. But we don't have many data on this violet districts. Okay, now let's go to the impact on economy. That is very interesting issue, that the government expenses are rising sharply because we have to finance for the health, for the social expenses of many things related to COVID. And then also the government income drops sharply as well. That means we have a new debt, and that means that the burden of debt is rising. And also interest expenses are also rising. So the Minister of Finance projecting the problem of COVID-19 to the economy is not only in this year, but also has impact to the coming years. So if you look at the red part, this is the interest for our debt. Okay, so from 2020, the debt is increasing like this until 2023, 24, and then hopefully can be reduced. Okay, so that means the fiscal space for financing welfare program is narrowing. So you can see that there's a big difference between 2020 from 49.4% to 46.1%. So until 37.9%. So this is the fiscal space is more narrowing, and then that means support for priority program is more limited for the coming years. Yeah. Okay, but we have also some interesting experiences. During the pandemic, many positive happening. Like we have the experience of improved case testing, tracing, and also therapeutic. The vaccination management is becoming very good using the latest IT technology. Better link between hospital and primary care, awareness of social safety in the context of communicable disease, and many other things that we can look at this page. Also, we have the more public and private partnership in that means like more community participations, strengthening social system, and many things. And we can see again back to the issue of the medical device and pharmaceutical product is becoming much better, and then better preparedness for pandemic. So many things, including the use of the digital technology for health services, because telemedicine, it was very helpful policy for treating patients that cannot be transported to the hospital or they have problem of social distance policy. So telemedicine is widely used for COVID-19 pandemics. Also the biotechnology development and other research. So actually we have many positive experiences during the COVID-19 pandemic. And then, so lastly, transforming the health system. That is the point that if we are looking to the future, what are the lessons learned that we can use for the future? So actually, when we look at the strategy of MOH in 2020, 21, 22, yes, actually to accelerate vaccinations and then to end the pandemic as soon as possible and to reform health system. So these are the three tasks that the Minister of Health is given by our President. And then the government of Indonesia also plans a health system reform that entails reprioritizations to accommodate, this is very interesting, the increased community needs attributed to the COVID-19 pandemic, but should keep the UHC coverage, yes, the universal health coverage, and sustaining essential health programs. And then we can understand that we have to improve also the very weak health system before the pandemic. So there are so many things that the government should organize in the future. So if you look at how the strategy restart, the vaccination achievement is very good actually. So we have it's like what we call the natural vaccination and vaccination working together, and we have the herd immunity at the moment. 99% of our Indonesian people already have the zero, survey, like the herd immunity. And then now we are here in April, and the question is whether this is the end of the pandemic. Yes, we do hope this is the end of pandemic. So now we have to look at the acceleration of health reformations. In this case, our minister used the word of transformation, and this is relatively fast in the process of change and becoming like a beautiful things or very interesting future, like a caterpillar become a butterfly. So this is the transformation. Yes. And then this is very important issue that when we look at the health sector reform is defined as sustained, resourceful change to improve the efficiency, equity, and effectiveness of the health sectors. And transformation is expected that it will be faster in the process of change. And very important issue that every crisis teaches us about the system improvement. So we have to learn from the pandemic experiences. So this is the mean of the transformation, how to transform the pre-pandemic health system becoming much better post-pandemic health system. So how we can do this? So actually, we still stick to the president vision about Indonesian population in line with the president vision to establish a healthy, productive, independent, and equitable society. So this is the vision of our transformations. And there are many indicators that still using the indicators before the pandemic. But we have the pillars and the foundations of transformations. So if you look at the themes, we have 6 big themes: the primary care, referral system, health resilience, health financing, human resources, and health technology. So these all transformation should be put in place in a well-coordinated mechanism. So this is very, very challenging. For example, when we look at the transformation in primary care, so we have learned from the pandemic experiences how to improve the case testing, tracing, and therapeutic, and then how the link between hospital and primary care, and the strengthened surveillance system supported by prominent epidemiologists, and also increased awareness of health and many other things in primary care. So how to transform, this is back to the issue that like the painful lessons or the bitter experiences we should use for transforming to be a better health system. And this is in the primary care. So we learn from the pandemic experiences. Also, transformation in the referral service. We have to learn from the pandemic experiences, like how the hospital safety, surveillance, and many things about referral system, the equity, so many things about surveillance system. And also the health resilience about the vaccine development, improve domestic industry for medical device and pharmaceutical product, and then better preparedness for pandemic. So all of this learning from the pandemic experiences is used for health resilience. Also for health financing, how to have like awareness of health finance mobilization is not only the government fund, but also community. They have to realize that it is not possible that only government that pay for the health service. Okay, so community should pay as well. So that means we have to increase the community participation, like the public and private partnership. And then also we have to have like a better policy dissemination system for pandemic based on real data. Who should be financed by the government and who should be financed by community or their own funding. We cannot pay for everybody in this matter. And then how the human resources should be developed, yes, like our experience in improving incentive system for human resources, human resource awareness on safety, and then also the more understanding of human resources shortage, not only for the remote areas, but also to the big city for international health service competition. So more understanding about this human resources shortage. And then also the health technology. So more use of the state-of-the-art of informatics technology. We have the Peduli Lindungi as like a software for tracing people, and also to make like a regulation for everybody that they have to have vaccination. So it's like a passport for communicable disease security. And then telemedicine, and also the development of biotechnology and research. So this is the health technology foundations. Okay. So as the closing of my presentations, so the pandemic has been a painful lesson due to the unpreparedness of health institutions, and then reveal the key weaknesses in the system. So we we can see that before pandemic, we had a very, very big problems of our health system. Okay, but at the same time, the experience has led from the very beginning to ideas for more effective responses to such outbreak and to transform and hopefully a better system for the future. So this is very, very interesting issue that we have to discuss, that COVID-19 pandemic is not only like a bitter experience or painful experiences, but also we have to learn from this experience to use it for more transform health system. And that means we have to have like an optimistic view for the future. And this is, I think, my conclusion, that we have to be more optimistic, and we have to have like a better health system in the future. Okay, let's discuss. Thank you.
Thank you, Pak Laksono. That was a very fast and at the same time very broad-ranging overview, moving from the earlier challenges that Indonesia's healthcare system faced to an overview of how they then dealt with it, and then ending up with us with the kind of optimistic message that this process of, as you put it, building the ship while sailing might actually lead to a stronger healthcare system in Indonesia in the future. That also leaves us many points to discuss. That's very nice. We'll now go to our discussant, Retna Hanani, and while she speaks, I also encourage the participants to type their questions in the Q&A to either Professor Laksono or Retna, so we'll go there after Retna's comments. Retna, go ahead.
Yeah, thank you, Ward. Also thank you to the organizer of IS4 webinar for inviting me to be part of this opportunity. I'm very happy to listen to Pak Laksono presentation, which is always helpful to provide the overview of what we are going to achieve after the painful lesson from the pandemic. And thank you again, Pak Laksono, for the thorough overview on our government strategy from coming out from the COVID pandemic. But in the spirit of optimism under systemic weaknesses that Pak Laksono has mentioned, I would like to share my screen just to help me organize what I'm going to say, because it's a very complex issues, and as Pak Laksono has shows in the last few slides, there are a lot of dimensions that we have to discuss in order to discuss our topic today. Okay, so I hope you can see my slide already.
Yeah, it works.
Yeah. Okay. So I share the sentiment from Pak Laksono that every crisis teach us with a possibility to improve the health system, and I totally agree with that, because if we look at the history of the Jaminan Sosial Nasional, the Indonesian Social Security System, the Undang-Undang SJSN, as well as the Jaminan Kesehatan Nasional, all of those programs were initially government response to economic crisis. So I do agree that a crisis situation could lead to a better healthcare system. But now I would like to focus on two aspects that I think is very important in order to create or to support any government reform in the future, especially in healthcare. When I look at Pak Laksono presentation on tax ratio, I share his view that we operate, that the healthcare system in Indonesia operate under a very tight financial support, especially coming from low tax ratio. But I want to add another factor that may influence on the financial support in Indonesian healthcare system. Because if we look at only on the tax ratio itself, we actually see a positive development in our tax ratio. The data from Ministry of Finance, for example, suggests that Indonesian tax ratio is showing a positive improvement. For example, from 10.8% in 2016 to 11.6% in 2019. And of course, as Pak Laksono has mentioned, it's decreasing during the height of COVID-19 pandemic. But again, if we look at the tax ratio itself as source of our government revenue, for example, it is expected to rise a little bit by the implementation of rise in the value-added tax, which rise from 10% to 11% starting this year. And also, if we look at tax ratio, I think other countries that have better index in universal health coverage, for example, Prof. Laksono may also aware of this, that they also operate in similar limitation. For example, if we look at Thailand, and as one of the best country in ASEAN countries who have a good universal health coverage, they operate their healthcare system within 14.8% of tax ratio. Yeah, in South Korea, it's also around 15.4%. So we cannot imagine that in ASEAN countries with better health, universal health coverage index, that they are operate in welfare system like in Scandinavian countries. In ASEAN countries, it's in Asia, for most of the countries that have a better UHC index, they basically operate in similar situation as in Indonesia. But if we look at the government investment in healthcare, Thailand, again, I use as an example, their government investment in healthcare is so much higher than in Indonesia. I agree that government investment is not the only source for financing health system, but I think it is also quite important that good government investment will lead to a better health coverage for all the citizens. And what I want to say again is also that in Indonesia, it seems to me that government of Indonesian budget allocations during the COVID-19 pandemic didn't really represent their concern on health issues. For example, if we look at the government budget allocation from 2020 to 2022, we can see that actually health is not the top ministry that receive government budget allocation, especially at the national level or APBN. If we look at the national budget, for example, in 2021, at the height of COVID-19 pandemic, yeah, the Ministry of Defense received 7.2% of government budget. And then the police office, the national police received 8.5% of the national government budget, while the health ministry only received 5.7%. In 2022, the budget allocation for health is improving to 7.5%. But again, if we look at the allocation for defense and the allocation for national police officer, it's still more than the budget allocation for health. So I share the sentiment from Prof. Laksono that that government investment in health sector is also quite limited. But I don't think that it's only because of low tax ratio, but it's also because of lack of government priority to healthcare, even during the COVID-19 pandemic. And again, if we look at Thailand and looking at the OOP, out-of-pocket expense, or the expense that patients have to pay when they access health services, Indonesia is still much higher than the countries who have better government investment in healthcare. Of course, even Indonesia has out-of-pocket expense more than Timor-Leste, which is a new country that maybe has more limited government capacity to finance their healthcare. So I want to end my discussion with some concern that I'm afraid with limited financial support and lack of government priority in supporting healthcare, I'm afraid that again, yeah, just looking at the experience of JKN, for example, which I think Pak Laksono is very familiar about, that this very limited financial support will be stretched thin to finance any attempt to improve the health system. And by having a very limited support like that, I think the expense will be borne out to the citizens. Because if we look at the health provision in Indonesia, most of healthcare provision is provided by private sector, which is private hospital, private clinic, and etc. And if we look at the finance, because Pak Laksono mentioned about community involvement, I think we can also say that even until today, most of the healthcare financing still supported by the patient itself or by the citizens, looking at the percentage of OOP that have to be paid by patients. That's my first point in relation to the importance of creating sustainable health financing, especially the possibility of improving government investment in healthcare. And secondly, I would like to look at the referral care, which Pak Laksono also mentioned in his presentation. My research also shows that the complex referral system in Indonesia lead to inequity of access to healthcare. And with the implementation of JKN, the National Health Insurance, this inequity of access is not only about geographical inequity, but also among classes. That Pak Laksono also shows that the richer population will have better access than the poorer citizens. But what I want to emphasize here, the referral system, the complex referral system, is a result of the limited support from the government in healthcare availability. Because in places where healthcare availability has to cater expanded demand from citizens due to the JKN, they have to do whatever they can in order to provide services to the citizens. And again, it becomes the additional burden for the citizen when they are accessing these overburdened health facilities. And lastly, and I don't think, because I mentioned it last, then it is not important. And I think it's a very important thing that I haven't seen in the government strategy to create health preparedness and resilient health system is acknowledgement of the impact of climate crisis. I think what the COVID-19 pandemic has taught us is that with the climate crisis approaching us and what we are experiencing today, shows that if we don't fully acknowledge the impact of climate change and climate crisis, then we won't be able to create a resilient health system. And again, our preparation will become as an emergency response rather than something that is systemic and structured. I think that's all for my discussion. Thank you. Thanks, Pak Laksono. I'm looking forward for your response.
Thank you, Retna, for these comments, which, if I very roughly summarize, revolve around whether the budgeting of the Indonesian government puts enough priority on healthcare to actually achieve that kind of transformation that Professor Laksono was talking about. And then Retna also emphasized the need to overcome inequalities between social classes and regions. Maybe we'll put that question first to Professor Laksono before going to the Q&A, the comments that are already there. Oh, you're still muted.
Okay, thank you, Ibu Retna Hanani, for your comments. Yes, I would like to stress one of the important issues of the future transformations about how to finance this process. So when we look at back to the issue of the fiscal capacity of our government to pay for the future health services, that is a big challenge. because at the moment we have to pay more debt interest. Okay, we have the narrowing fiscal space. In the same time, so we have to acknowledge that the economy is still in the what we was like recovery. Okay. Now the question is how to finance the transformation. Is it only paid by the government mostly, or society should also pay? That is a big issue. So when we look at the Indonesian economy, that we have a very slow and low tax ratio compared to GDP, is around 10%. That means population or the society should pay more. And if we go in the plan statement, the rich should pay more. Okay, and then the limited government finance should be focused to the middle or the low income of the society. That is the point, that like a political agenda for the future. And for the BPJS, we have to emphasize more that BPJS or the social security, this is not a comfort pillow for everybody. This is like somehow it's like a social safety net. Okay, although it's not too bad as maybe when we have the economic crisis in the 1990s, but BPJS is not a comfort pillow for everybody. That is the point. So when we look at the Thailand's experience, they have like a 2 tiers of the health services. One paid by UHC, by the government, and then the upper tier is paid by the society. So I don't know in Holland at the moment what, yeah, do you have also tier system that also private also can pay for the health services in a more luxurious services? This is happening in Thailand, yeah, in developing countries. Yes, that is the point. Who will pay for the transformation? That's a big challenge. Okay.
Yeah.
Yeah.
That's a key discussion, I think, political discussion to be had. In the Netherlands, we have an obligation for healthcare insurance, where you pay a little bit more for better services, but it's not very redistributive, not as in the sense that you are promoting here. But this is definitely seems to be a key debate for the future. I'm going to move to the questions in the Q&A, and I'll start with the question that asks about an evaluation of the political leadership during the corona pandemic. Hans Pols is asking, just wondering, how bad was the Minister of Health, Terawan, for the COVID crisis in Indonesia? How much worse did his terrible leadership, according to Hans Pols, make the situation? I'll ask Pak Laksono to evaluate the political leadership here.
Yes, actually, this is at the beginning of the pandemic. Yes, all of us understand that many political leaders across the world, they have like a confusing idea how to solve this, how to deal with this pandemic in the beginning. And I think the same with our government and our head minister. And the point that I will address, that by the time that I mentioned also in my presentation, we have a lesson learned gradually from the COVID-19 pandemic. Okay, and then when the ministry is changed, the leader is becoming not a doctor, but our current minister, he is like a professional in banker, yeah, okay, and he is expert in management. He is expert in the crisis management. So during the crisis, yes, I think the biggest contribution for controlling the pandemic is a good policy and a good management system, okay, and supported by a good communication. And this is the things that we learn from the pandemic. Okay. But in the beginning, yes, I agree with all the people that in the world that every country, they have big problems in terms of how to deal with this pandemic. Until now, if you look at China too, they have some of the lockdowns activities happening in China at the moment. Yes. I don't know in the Europe, but I read in the Europe even some people fight in the street because this kind of policy. Yes, this is the problem of everybody.
Yeah, including that fighting in the Netherlands, where indeed the political leadership raised high emotions, particularly during the these corona policies have been very sensitive. In that sense, I'm happy that it's behind us for now. I'm going to take two questions together because they address a similar point about health inequity. First, a question by an anonymous person who says a very sad observation is that areas outside Java are still lagging far behind in mass education, testing, treatment, vaccination, and so on. How can we close this health inequity for future pandemics? So this is about regional inequity, but there's also a question from Gamala Dewi, who talks about, I think, her experiences, how to get proper treatment. Even if you have BPJS, you still need to go to private clinics, which would mean that for local hospital, the treatment is not at standard yet. So that relates to a more class or social-based health inequity. And she asks, do you think that increasing on the investment of healthcare will tackle these poor services? So two questions. I guess we'll start with Pak Laksono, but maybe Retna has a few on this too.
Yeah, yes, I think we can understand this problem of inequity because our population is huge and the archipelago, like a feature of Indonesia. So we can see that the eastern part of Indonesia, the Maluku Islands, NTT, Papua, they suffer from problem of access, including the vaccine and other therapeutic during pandemic. That's why we have to learn from this pandemic experiences. For example, if you look at like detecting the case. So before the pandemic, actually we rely on labs, laboratoriums. But at the moment, our government is trying to have more lab, not by using lab, but by household home care detection devices. That like malaria, it is like a rapid diagnostic test. It can be done by everybody. Like the antigen, you can see that, like the same with the antigen in detecting COVID-19. And this is a good ideas for narrowing the problems of inequity. Okay. And then back to the issue of inequity in BPJS that the second question mentioned, that yes, we have to be very clear that at the moment BPJS inheritance, like they have the legacy of the government employee health insurance, PT Askas, Askas Indonesia. And when the policy was developed, there is a policy that the medical benefit cannot be lower than PT Askas benefit. So actually our medical benefit is so large. Yeah. Even if we compare to Thailand, the hemodialysis in Thailand, it was given after the 5 years of UHE implementations. But since the beginning, we provide like hemodialysis as one of the BPJS benefit. And we have also the drugs for cancer. So many expensive drugs also available in BPJS. But Indonesia suffer from limited distribution of medical specialists and hospital. So we cannot distribute like drug for cancer if we don't have expert in cancer. Okay, so it is very, very clear that all of the costly medical benefit will be used by people in the big cities that close and the access is good to the hospital and medical specialists. So this is the problem of how to make BPJS as like a comfort pillows or beds to everybody, or it is a social net. That is a big question, still up to now. And it is difficult to reduce the medical benefit after we enjoy for more than 80 years of implementation. So we started from big medical or large medical benefits, and we suffer from the issue of whether we can afford to pay for all of these medical expenses. That is the problem at the moment. It is like a haunted problems, in my opinion. It will be like in terms of the pandemic COVID-19's impact, like becoming parallel. We have to solve the problems of before pandemic COVID-19 and after pandemic COVID. That is the problem. Thank you.
Thank you. Retna, very briefly, also to you, do you think Indonesia is on track of addressing these inequalities in healthcare access? And maybe in the chat, you can answer Aliza's question to you.
Yeah, I think what we need right now is truly a meaningful reform on health financing, because I think government investment is truly necessary for this, because if we look at geographical inequity, for example, no private sector won't be willing to invest in eastern part of Indonesia because economic of scale just doesn't add up. So in that sense, government investment is really crucial to be part of the financing. And secondly, what I really learned from the COVID-19 pandemic is the importance of strengthening JKN. JKN is the only way that we have today in order to decrease the out-of-pocket expense that creating the inequity in our health system. So if there is no sufficient support for JKN, and if we keep focusing JKN as part of the expansion of social safety net, then I'm a little bit pessimistic about the future of health system reform to be more equitable for the citizens. But again, this has to be defined in a very strategic, and I agree that it doesn't have to be in the current system, but I think there has to be more government investment in healthcare. I think that's my position. What?
Thanks. That's a clear point. Thank you, Retna. And then we have a nice question here, which would be for a closing statement of Professor Laksono from an anonymous person who asks, if you have a policy what would be your first priority to fix the current health system? So what would be need to done first? And we have a few questions that we could not address fully. So thank you for those questions. So I invite you to type them. Prof. Laksono, for this question.
Yes, I think the first thing is how to secure the financial support for the transformation. That is very, very important issue. In the background of we have so big difference between the remote and the developed provinces. And then for this financial improvement or strengthening, we have to look at how the strength of the government and then how the community should pay. So one last sentence that the out-of-pocket or the private expenditure should be increased from the rich community for the middle and the upper class. But for the middle and the lower, the government should focus their limited budget for them. This is my answer. Thank you.
Thank you. So a plea for a much more redistributive healthcare financing system, having the broadest shoulders shouldering the biggest cost, so to say.
Yes.
that's a very clear conclusion of this seminar. I thank the two speakers for giving us such a broad overview of what Corona did, but also where the future of healthcare in Indonesia should go. And I think the attendants for their questions, if we could not all fully answer them, I apologize. I want to just close by mentioning that these IS4 seminars will continue. We don't have the next session planned yet, but this will be likely in September. There will be a new one where we'll continue showcasing new social science research and key political debate and policy debates going on in Indonesia. So I hope you will stay tuned for more. And with that, I will close this session, and I thank you all for participating and attending.